Hi, it's me, Shirley Gutkowski, for part 2 of our tongue tie discussion and the far-reaching consequences of having a tongue tie. I'd like to let you know that I am the owner of Primal Air, a oral-facial myofunctional therapy practice and Pt2 breathing retraining practice here in Sun Prairie on Main Street. And we are very excited by some of the really awesome things that myofunctional therapy has been able to provide to the clients that we're seeing. So you can look us up on our Primal Air website if you like. And thank you again for joining us for A Spot for Health. We love doing this show and bringing you different aspects that maybe you haven't heard of and maybe you should be hearing, and finding new places to achieve health through some of the other health practitioners here in Sun Prairie. We'll be ramping that up very, very soon, as our schedules have been kind of crazy over the summer. So I know that you're tired of seeing the same episodes over and over, and you can be rest assured that more episodes are coming your way. So what we were doing was, last episode, was talking about tongue tie and the far-reaching consequences of tongue tie and how dentistry has a very high tolerance for tongue tie, even in patients that are adults. And that is changing because we're finding that tongue tie is really kind of the crux of a lot of problems that center right on the airway. So what's happening right now in dentistry is that dentists are looking a centimeter back further into the airway, and ENT practitioners, ear, nose, and throat practitioners, are also looking more towards the mouth instead of just the ears, nose, and throat, and looking at the airway. A real important resource would be Dr. Stephen Park's book, Sleep Interrupted. That was a really eye-opening book for me, especially when we talk about tongue manipulations and where the tongue lives in the mouth and how it related to gastric reflux and silent reflux in your sleep. So even things like that are associated pretty tightly with tongue tie. So when we left last episode, we were talking about children that have behavior problems in school and how that may be contributed to by an airway problem or an inability to sleep, which may or may not have something to do with a tongue tie. I want to make sure that tongue tie doesn't equal sleep problems. Tongue tie can equal sleep problems, and it's something that maybe we should be looking at more in dentistry and in healthcare in general. I also want to point out that the tongue is the only muscle that has a free end, right? It's just, so it's only attached in one spot, and that's the hyoid bone, which is right here. So the hyoid bone is supposed to kind of protect the thyroid and the airway from attack, and that's why those old karate shows, remember in the 60s when somebody would give a karate chop, they'd chop them right here in the throat, and they would either crush that hyoid bone or just smash into the airway. And so that's where your tongue is attached. So if it's attached here and it's attached in your mouth, you can see why that would create such a tension here in your neck. If you look on YouTube and look for videos of people who have had a tongue tie released recently, every single one of them's like, oh my God, I cannot believe how much tension I had in my neck and shoulders, even though I had a high-stress job or I was on a computer all the time. Having that tongue tie released really allowed them to live a better quality of life. So the other thing from last time was I couldn't think of the O word in children that had behavior problems. And I did remember shortly after we ended that episode, it's oppositional behavior disorder. So OBD may also be attributed to a tongue tie and or airway problems. So here is another study that we look at quite often or use quite often when we're describing these problems with airway in children with behavior problems. This is from Istanbul, and I know it's hard to relate what happens over there to what happens over here in our children, but even there, children snore and children have their mouth open too often. You know, a lot of parents in my day were always, close your mouth, or why you have your mouth open kind of thing. I think we have a different level of tolerance now here in the United States in this time because we don't want to be ragging on our kids all the time, but closing the mouth is really important. This study here looked at children's behavior who snored, and the teachers reported that there was a much higher incidence of behavior problems in the children who had habitual snoring. So that is another example. This here is just a picture. I know we've all seen these pictures on Facebook, on these groupings of pictures of kids having meltdowns for no apparent reason. This kid is having a fit because his mother broke the cheese in half. Who hasn't lived through that, right? But we know that these are neurological problems. The Weston Price Foundation was started by Mrs. Fallon, and she talks about a lot of different things about food and nursing in particular. And what Dr. Weston found is that in the tribes that ate the traditional foods, the children were very, very calm, and they didn't have these meltdowns. But those children were also nursed for a very long time, at least 1 year, and their maxilla had expanded to its genetic potential, and they had a lot of room for their teeth and a lot of room in their airway. This study here shows that the children that have obstructed airways are very susceptible to behavior problems, and we're finding more and more studies like that. They have behavioral difficulties, they have problems with their peers, they have aggressive conduct in school, and most importantly, they have impaired executive function. And that means that their ability to identify consequences of their actions has been impaired. That comes early in life and then slowly gets better and better. And in kids that have airway problems, don't ever really develop that executive function, and they don't understand that smoking in the parking lot between classes in high school may lead to them losing their driver's license later, and that's going to be a problem when they're 23 and they wake up one day and go, oh, I still don't have a driver's license. So it's that kind of thing, and that's why it's so important to address these problems early. We also find that children with ADHD have higher incidence of learning disabilities, and they have a higher chance for anxiety, or they exhibit anxiety symptoms more often, and they have lower social competence. So all of these things together really make it that we need to improve our diagnostics for airway problems. These kids are suffering for a really long time. In this picture too, you can see there are 3 girls sleeping. I think they're all girls, and only one has their mouth open. So we're seeing that this is a problem, but not everybody sleeps with their mouth open. It's not normal. And we also know that up until today, it's between 4 and 5% of people have a tongue tie. But I think, and most of the people in this realm right now are thinking that that's extremely low, mostly because we are not diagnosing these issues. I've had a client who was 55 years old with a tongue tie that reached all the way to the tip of his tongue. He couldn't put his tongue out past his lips. And he's been to the dentist a number of times. It's never been identified. I have another one who's 29 years old, and he's making an appointment today to have his tongue tie released, and another in their mid-30s with TMJ issues that will probably never be resolved until that tongue is released. So all of those things are really, really important, and I'd like to make sure that we address these problems as early as possible. Obstructive sleep apnea, in this study here, this was a case study, mimicked attention deficit disorder. So this patient, this client, this case was of a young man in his middle 20s who had been diagnosed with attention deficit disorder, and he was taking the medicines that we usually prescribe to those kind of clients, those kind of patients. And he would get better when he would be treated with antibiotics for his allergies. And we know that that would shrink his tonsils and his adenoids. He would also be breathing better during those times. So what happened then in his middle 20s is he had a sleep study, and it was discovered that he had obstructive sleep apnea. And that obstructive sleep apnea was causing his attention deficit disorder. And the researcher or the case presenter went so far as to say that the original diagnosis was in error and that he never did have attention deficit disorder. So we need to be more aware of all of these kinds of things. This is the prevalence of sleep-disordered breathing in children with asthma and behavior effects. And we find that you can separate asthma and breathing disorders by behavior. So kids who have asthma don't have behavior problems, but kids who snore and have obstructed airway in their sleep especially do have behavior problems. So it's not the same, but it kind of is. It's about airway and sleep. This video here is not going to be a video for you. It's a still of a video of an interview that I did with Dr. Michael Gelb. And he's a dentist in Manhattan, and he was on this TMJ track, and he was treating his patients that had temporomandibular joint disorder. And what he found is that he had to keep going back and back and back further to younger and younger patients, which he never thought he would see child patients. And today he is one of the founders of the Foundation for Airway Health, and he is treating and having children in his office that are under 3 years of age, looking at their airway. And he says that teeth may be there not so much to chew, but maybe they're there more to keep the airway open so that you have a nice airway open. If you can imagine all your teeth are gone, how that will all collapse. And he also says that we should be seeing children with crowding before the age of 3, and we should be diagnosing these airway problems at a very, very young age, and that orthodontists should be in the brain health department, that should be their goal, because once you get the mouth the right size, it opens up the airway to be the right size, and that allows for development of the brain. And so far, he's the only person I know who talks about that, and I think he's probably right. Most orthodontists are just, mainly interested in straight teeth. Not that that's bad or anything, but we do have a crowd of dentists who are coming up onto this airway way of looking at things. The most prominent is in California. Why does everything start in California? I don't know, but it sure seems to. And so we're going to be seeing more and more of that kind of thing. So as you hear about this thing, don't be so afraid. So how in infancy do we do this? First and foremost, we need to make sure that the babies are breastfed. When we talk about breastfeeding, mostly what we talk about is the breast milk. Especially in dentistry, we don't like to have children on breastfeeding for a long time because somehow we think that melts teeth. Obviously, if you go on the evolutionary track, we would have all died a long time ago, or we wouldn't have teeth at all if breast milk really did corrupt teeth. So breastfeeding is really important. Children who are not breastfeeding properly have a lot of signs and symptoms, one of which is these little like blisters on the lips. This is a sign that there's a problem with breastfeeding. This is a picture of breastfeeding, so sorry for the people that are sensitized to this kind of thing. And the the nipple of the breast needs to go almost all the way back to the throat. And it's not the squeezing that draws the milk out. It's not the squeezing of the nipple against the palate. That's what grows the palate. What gets the milk out is the suction that's created when the tongue goes down. So the tongue has to go up and down in order to express the milk. In a tongue tie situation, the nipple never gets back far enough and it stays in the front, and that's what causes so much pain. These women are having bloody nipples in a few days or a week's time. It goes really fast and it's really disheartening. This is not breastfeeding. We have a lot of women who are pumping their breast milk, and this is why it's so important when we look at what am I trying to say? Sweden or some other European countries where they are very high on breastfeeding and very high on long maternity leaves. And we aren't here. And I don't know, maybe this is part of it. We also know that this is not breastfeeding. This is never as good as the breast when we talk about facial development. This is a problem. And then, because I don't know why, but these sippy cups have seemed to taken the world by storm. Once the kid is 8 or 9 months old, they can start learning how to drink from an actual cup. These cups are very detrimental to the shape of the face and the development of the face, and they should not be used past a year old. I had a patient last spring who just for Easter had purchased, I don't know, one cool little sippy cup for each of her children. One was 5 and one was 3 or something. I'm like, you're going to have to take those back. My own children were drinking from a cup by age 1. We used to have like a tippy kind of a cup, and it would tip and roll. It would always be upright, and then it had a cover that went into the cup about 1/2 inch, and that cover had a little slit, and the milk would just, or whatever was in there, water, would just come out slowly. I hate to say slowly because it makes it sound like it just dribbled out. You could spill it, that was possible, but that's a learning thing, right? Yes, it's a mess, but you know, they do it a few times and they don't make such a big mess. And they drank when we were eating, and they may have had a cup, you know, of water or whatever later in the day or throughout the day, but it was in the kitchen at the table. It wasn't that they were dragging a water bottle around with them. I don't know when that started happening, but it's not required. This is the new type of training cup. There are a number of videos on how this works on YouTube. It's called the Wow Cup, and it's hard to spill, but the child can learn how to use a cup. And some of them even have handles so that you can drag them around wherever. I mean, if you're stuck in a car for a long time, then I guess you probably want to bring something along. But this is a pretty decent way to train the child to use a cup. So don't be afraid to get your kid involved in growing up. Those are all skills that add creases into the brain, and the more creases, the better, right? We like to have a lot of activity up there as the brain grows. So thumb sucking can also be interfering with a lot of things, or be looked at as a warning sign that there's a problem. Very likely this child is having an airway problem, or that their tongue is too low or it's tied. I was talking to a young mother the other day with her 9th child, and this last child is the only one that had a tongue tie. And it took a little while before they got it released. I think the baby was 2 months old or so. And the baby was a thumb sucker until that tongue was released, and suddenly, boom, she did not have a tongue tie any longer. So this is what happens when you get rid of a thumb sucking habit, right? So we in dentistry are very concerned that we're going to jack up the teeth by not getting the thumb out. One of my own children had a thumb sucking habit until he was 7, And we agreed together that he would find a way to not suck his thumb in the night. And we landed on a Band-Aid, because Band-Aids taste pretty bad. We tried everything else. But he sucked his thumb since before we got him home from the hospital. And it did jack up his teeth, just like this picture here. And as soon as we got rid of that thumb, in short order, his teeth were straight. So the teeth go back into alignment very quickly if they're given the right tools. So I'd like to make sure that you don't stress that out. If they need help later, that's another thing. But they will get nice and straight in short order. There are other ways to do it. I don't know that these are the ways that we would teach at Primal Air, but we do have a little system to get a kid to give up their thumb habit. This child in these pictures is using an appliance, a trainer, to straighten the teeth out, and you can see in the next picture here that his teeth are just as straight as the child who didn't wear a retainer. So unless there's a big issue, the retainer isn't always necessary. But if we're not addressing the cause for the thumb sucking, that's an entirely different problem, right? They may be overcoming the thumb habit, but the reason for the thumb habit may still be there. So we have to look a little further into these thumb-sucking children as to why it is that they're sucking their thumb. So the other problem with bottles and with thumb sucking is the eustachian tube. Does everybody even know what a eustachian tube is? If your kid had 1 million ear infections and they had tubes placed in their ears, then you know what the eustachian tube is. And using a bottle and sucking on the thumb can interfere with that eustachian tube. In an adult, the eustachian tube is like this. In a baby, the eustachian tube is like this. And when they're laying down, their saliva can get into that eustachian tube and interfere with the equilibrium of things in the ear. Let's just say it that way. I don't do a lot with ear infections, but I do know that we can do more for those children, and we can get rid of their ear infection by using xylitol products pretty liberally at every diaper change. This product was developed by an osteopath in Texas, especially for children with ear infections. And they were using this product before it was a product to get 90% of the ear infections under control. You cannot use it to get rid of an already happening ear infection, but you would use it as a preventive, and you can reduce the ear infections dramatically. So this is the diagram here of the thing that I just did with my finger. You can see that this eustachian tube is pretty flat in an infant and pretty angled in an adult. So when we lay our babies down to sleep, right, we're taught to lay them on their back. But I don't know, this picture really brought home some images for me with my own children and my grandchildren. When I laid them down, they would kind of go like that, and their chin would go down. I'm like, how do they even breathe? And this picture here kind of shows a washcloth or a hand towel kind of under their shoulders and under their neck to give their neck a little bit of relief. When you talk to chiropractors and talk to them about babies nursing, they talk about how the arm, the mother's arm, will affect that curvature in the spine and set that curve the way it should be. So there's a lot of interaction here in a lot of different ways when we're talking about these infants and how infants are fed. So in our world here, we have a lot of people that we should have on our team to get better answers for everybody. And in that team should be an orofacial myofunctional therapist, a chiropractor, a dental hygienist, a dentist, a lactation consultant, a speech-language pathologist. All of these people can help identify this problem. When the blogosphere starts asking questions about how mothers were identifying tongue ties. Most of them found that the child's tongue was tied by themselves. So they didn't get the information that they needed for that from their own practitioners. So as a practitioner, I think we have a little room for improvement with respect to that. So this is an unreadable list of, of symptoms that can occur if you are an adult with a tongue tie. You may find that it's harder to swallow liquids, that you can't swallow pills, for instance, that you have jaw pain or TMJ pain, that you have difficulty swallowing, that you have trouble eating certain textures. As we talked about last time, kids who are really fussy eaters, who don't like to chew foods, chewy foods are there's a pretty good chance that they also have a tongue tie. So those kinds of things are really good little flags for you to think to yourself, maybe this tongue tie is a problem. With respect to sleep problems, we also see a lot of bruxing, tooth grinding, restless leg syndrome, and those are all ways for the body to stimulate the body to wake up and not sleep as deeply. So with my training and with myofunctional therapy and other myofunctional therapists around, you will find that this is a really important thing that we offer to our clients, are tie-ins of these different ways to do things. We know that there are a lot of studies that show that myofunctional therapy and doing or repeating techniques that we teach to our clients can motivate those muscles to act more appropriately and reduce the sleep apnea indices. So just by doing these exercises, it makes it sound like you're going to be sweating with the oldies or something, but they're really practicing techniques, and those techniques help develop new neural pathways between your face and your brain, so that it works better and more appropriately. This was a meta-analysis that looked at a host of studies and showed that the apnea-hypopnea index was reduced by 50% in those clients that went through myofunctional therapy. So that's a pretty big number. But I'll tell you that if your tongue is tied, your myofunctional therapist is not going to be able to give you much help or relief. We need for that tongue to be really free in order to practice these techniques to get those benefits. So that's it for today's episode of The Spot for Health. My name is Shirley Gutkowski. Thank you for joining me. Make sure that you take a minute and share these episodes with friends and family, either on the internet at ksun.com or on Facebook and some other ways. There's a bunch of ways to share these episodes. Have a great rest of the day, and look around and you'll find that there are other places in Sun Prairie to get the health that you're looking for. Have a great rest of the day.